My topic is pancreatico-gastrostomy, bulbogastrostomy, endoscopic ultrasound guided pancreatic duct intervention, to whom and how. The theory of pancreatico-gastrostomy is to create a fistula between the pancreatic duct and the stomach, or between the pancreatic duct and the bulbus. This will be performed under US. We will insert a wire under US, and then on the wire a plastic stent. We will see later. We have three techniques. The first technique is a rendezvous technique. The rendezvous technique is the insertion of a wire in the pancreatic duct. The pancreatic duct crosses the papilla, you catch it with a duodenoscope, and we saw a rendezvous technique in the pancreatic duct yesterday during a video. And that's a good technique for pancreatic duct because you have not a lot of complication. The two other technique is insertion of a stent in the bulbus or through the stomach. The bulbovirsungotomy needs a standard anatomy because the patient needs a bulbus to have a bulbovirsungostomy. And virsungogastrostomy is for patients with altered anatomy. Virsungogastrostomy, as you see in this large publication, has less technical and clinical success than bulbogastrostomy, because bulbogastrostomy, your scope is in the duodenum, and the scope is blocked by the duodenum, and once you have punctured the pancreatic duct, it's easier to work. In which patient in chronic pancreatitis, you know that in case of pancreatic duct dilation beyond fibrotic stenosis or stones inferior to 5 centimeters, ESGE recommends the placement, an endoscopic treatment with a placement of a 10 French plastic stent that you change every 6 months or in case of recurrence of symptoms. With this plastic stent, you have a long-term decrease of pain, described for 77.5% of the patients in 536 patients in a meta-analysis of 9 studies. The morbidity of ERCP is 8%, mainly because of pancreatitis. But what to do in case of ERCP failure, and it can happen, you can sometimes not cross the stone. That is a place of pancreatico or bulbogastrostomy for this chronic pancreatitis. You have another main indication. It's a postoperative stenosis, postoperative pancreatico-jejunostomy or postoperative pancreatico-gastrostomy. These delayed complications are a rare event. It's because after Whipple surgery, your survival is low, except if you have operated benign IPMN now. That's why pancreatico-gastrostomy increase in postoperative stenosis. And these stenosis are very frequent in 25 to 60% of the cases in radiological series, but most of the time they are asymptomatic, and without symptom, no treatment. The symptom can be pain, pancreatitis, exocrine pancreatic insufficiency, and symptoms and stenosis happen in 1.5 to 11% of the patients in a follow-up of 18 months. So that is the first pancreatico-gastrostomy performed by Marc Giovannini in the Congress of Jacques de Vier in the beginning of the century. You see the image is a bit old, and he punctured. He performed his first gastrostomy during a congress. It was, I think it's not possible now. He punctured the pancreatic duct, and then he could opacify that will change. Could opacify the pancreatic duct, and is not well placed because you see the main part of the pancreatic duct is behind, so he has to do that to place the wire on a loop behind him. He used at the beginning a huge cystostom. Now we use the 6 French cystostom. He has not 6 French cystostom at this time. And after using this French cystostom, he placed the first stent in pancreatico-gastrostomy.
Donc avec un échec et donc un
Maybe you can switch off the...
imagine une petite pratique avec un calcul hyper dense et on a déjà fait le cas pancréatique à ce niveau, stable. Voilà. Je ne pas des images, on n'est pas testé, donnez-moi les lignes, s'il vous plaît. Je me l'adore bien, Estelle. Il faut. Alors, ce que vous allez faire. Alors, on va essayer dans cette position-là. Ah, voilà, là, on va arriver, ça y est. Ah, bravo, on dira bravo après. Vas-y, enlève à peu près de la sténose. Pour pouvoir pousser la prothèse. Ouais, je pense que ça va le faire. Ah, voilà, la sténose qui est là. Peut-être que le but va passer, hein. Alors, je ne sais pas où la limite de la prothèse, hein. Alors, vous pouvez la faire bien l'image, s'il vous plaît, me faire une image un peu plus grande. Voilà, merci. Donnez-moi le
wire.
Oui, tu vas y arriver, c'est bon. C'est pas une prothèse biliaire, c'est une sténose. Ah, d'accord. Voilà, oui, je passe pas, hein, donc je fais une grosse boucle, là, voilà, je ne cherche pas à passer, voilà.
After inserting the wire exchange, inserted of a 6 French cystostom. And because pancreas is very hard in chronic pancreatitis, it's the case in hepaticostomy. In hepatico-gastrostomy, we never delay it, but in pancreatico-gastrostomy, it's the case in which we dilate the fistula with a balloon of 4 millimeters diameter. So the cystostom is placed, and now it's, you see the nurse dilating up, take the balloon, and after he could place a stent in place in the pancreatic duct. It's not necessary each time to have a stent in the main pancreatic duct, but in the main part, but you can place it just in the pancreatic duct, it's enough. We will cross this one, but it's another puncture, but we have no time to see all the video. That is another video, and you see the placement of the scope. It's like cholecystectomy. We are in the bulbus, so it's a pancreatico-bulbostomy. The principle is the same. You puncture the pancreatic duct, but your scope cannot move. So once you are in the pancreatic duct, there's no failure. It's not so easy because the pancreatic duct is not the bile duct. You know the pancreatic duct is not straight. The bile duct is straight. So when you insert the wire in the bile duct go straight ahead. Here you see the nurse or Mark try. He failed, so the nurse try again, and they could not go in the pancreatic duct. So no, doesn't matter. It did the exchange, course with the cystostom. The cystostom arrived. And now, once you have the cystostom in place, you cannot injure your wire because if your needle, there is a risk of injury your wire. So the nurse manipulates the wire, and our nurse is fantastic, and she crosses the pancreatic duct. Mark is happy. And now we will dilate and place our stent of 7 French. Pin diameter of the stent because it's not easy. 7 French, 7 centimeters most of the time. We will wait for the end. The stent is in place. So I like Star Wars. So after placement of stent, 1 month after, we place the second stent. The second stent to avoid delayed complication. The second stent allows to block the first stent. And in case of obstruction of the stent, like placement of 2 stents in drainage of pseudocyst, the pancreatic juice will be able to cross between the 2 stents, and so we create a permanent fistula between pancreas and stomach. It's not so easy because you place your stent with a US scope, and now you work with a duodenoscope, and the axis is not the same. So it looks easy because you have already a hole, a fistula, but in fact you have to find the good path, and it's not the same that US. So it's the same technique. You insert your wire, you dilate, and you place your second stent. But we have some failure to place the second stent, and because of this axis. And each time we place thin stents, 7 French. And then you have no delayed complication. Yes, you have, of course. It happens all the time. And we can have obstruction of the 2 stents. So in this case, there can elevation of the stent, or in the case you can expose the wire side by side to the first stent, because the second stent you can also remove the first stent and place 2 wires related with a balloon, or not in this case because we remove 2 stents, and place a second or 3 more stents. 2 stents to block each other and to create a permanent fistula and the leakage of pancreatic juice in the stomach. An interesting paper about pancreaticogastrostomy is a paper from O et al. It's a pancreaticostomy using metallic stent. Sorry, it's in French. I'm sorry, I didn't see. They included 25 patients with painful obstructive pancreatitis who underwent a US-guided main pancreatic duct with a fully covered SEMS after failed ERCP. It was successful in all patients, and the advantage of the metal stent, it's easier than the plastic stent to pass the stenosis. And if you cannot pass the stenosis, you can remove the stent, dilate again. With the plastic stent, you cannot. So it's a good thing to maybe to place this metal stent. Now, since this study, we know that the metal stent is not good for pancreatic duct, but maybe in the future you will be able to place a metal stent and then quick replace it by a plastic stent. So that's a very interesting study to make easier the US pancreaticogastrostomy. In the literature, you have a lot of paper. You have some paper, but very, very, very various data. You have two main indications. We saw them: chronic pancreatitis and postoperative stenosis. You have other indications like pancreatic injury, post-pancreatitis. And you see the technical success is 40 to 100%. The morbidity is 0 to 35%. And delayed complication also very variable, 0 to 55%. The clinical efficacy is also not standardized, 60 to 100%. What it means, it's a retrospective study, and it's difficult to have serious data. The technique is not standardized. You have a lot of material used. You see 19 gauge, 20 gauge with a lot of guide wire. You have a lot of dilatator. That's what we use. A plastic stent 7 French, and we use a cystosome of 6 French and the balloon of 4 millimeters. We agree, I think, on the rate of delayed complication, 50%. That is the paper with the longer follow-up, 37 months. It's not so easy to follow these patients. It's chronic pancreatitis. They do what they want. They can not to come at the visit. But 50% of delayed complications, probably the number confirmed by Dalal in the large series of 44 patients. They have also this this rate of delayed complication. Just indication, a backup to the indication, because in this review, we see indication, it's maybe better like that. Failed pancreatic duct cannulation by conventional URSCP, pancreatic duct disruption as a result of acute pancreatitis, severe pancreatic ductal stenosis and obstruction due to chronic pancreatitis, anastomotic stricture at the pancreatico-jejunostomy site and pancreatic duct fistula. But the most important thing is that indication must be symptomatic. So pain is the main indication of this therapeutic indication. Exocrine pancreatic insufficiency, probably, but not all the authors agree with this indication. What is the best indication? Chronic pancreatitis of postoperative stenosis. We try to compare both indications in our series. We didn't find any difference in technical clinical success in the decrease of analgesic. We didn't find any difference in complication in or severe complication. Just a word, if you want to perform US enteroscopy instead of US pancreaticostomy, both are very difficult, but the rate of technical success is better in US pancreaticostomy. And don't forget also, it's most of the time a treatment for comfort. It's not an emergency. And you see that is a natural story of pain during chronic pancreatitis. And if you do nothing, the pain will disappear. So you have to think about this treatment who can be who can have severe adverse events. So in conclusion, pancreaticogastrostomy and pancreaticobulbostomy under US are feasible with a rate of acceptable complication. Indication remain rare, and so the procedure is a rare event. In the literature, it's 4 patients per year per center. The therapeutic endoscopy is for convenience, for comfort. Be careful. And surgery can be theoretically discussed in case of chronic pancreatitis. As you know, surgery, early surgery can be efficiency. The natural story of the pain in pancreatitis must not be forgotten. Thank you.